Okay, great. Well, you guys almost made it through the whole day. It's a long day, you guys. We're going to talk about Mycobacterium. This is what we're going to spend some time on. This is not something I think we do much in training programs anymore. I remember going through my residency and certainly my fellowship in infectious disease, and very few people know a lot about TB. The people that really know about TB are actually trained in other countries where TB is a lot more common. So let's talk a bit about non-tuberculous mycobacterium, then we'll talk about TB disease and latent TB infection. And I think before we start, I want to make sure we're all using the same language. And that is, if you are in a room where someone has active tuberculosis or any mycobacterial infection, say they have a cavity in their lung, they are expelling organisms. And you, if you're within I like this analogy, on an airplane, if you're 2 seats in front, 2 seats in back, 2 seats to the side, for greater than 8 hours, you're exposed to tuberculosis. That's what exposure means. Exposure is an epidemiology term, not really a clinician term. So us as clinicians should not be using the word, oh, I was exposed to TB, unless you can quantify 2 seats in front, 2 seats behind, and to the side for greater than 8 hours. That is what's called an exposure. But suppose you are in that airspace for 8 hours and you breathe in some organisms. You are, by definition, infected with Mycobacterium. That is what infection means. The only way we measure infection is either a blood test for tuberculosis or a skin test. That is infection by definition. It means your chest x-ray is normal, you don't have any lymph nodes, but you've breathed in the organism. Disease is exactly what it sounds like. Disease is a cavity in your chest, bacteria in your meninges, a big lymph node, a draining abscess. Usually it's lung, though, it's pulmonary. That's what disease is. So exposure, infection, disease, these are terms I'm going to use through this talk, and I want to make sure we're being very clear about it. So when I say this, 1 out of every 3 people in the world, 1 out of 3 in the world are infected with TB. That doesn't mean 1/3 of the world has tuberculosis. It means that they carry the organism. And we'll talk about what is then your risk of developing disease throughout the talk here. So I'm just going to the next slide here. Okay. Do I need to point this at something in particular? Point it up. Doop. Yep, there we go. Yep, I have no relevant financial relationships with any companies to disclose. And on my first slide here, I can go back a little bit. It had my name, and then underneath of it, it said Public Health Solutions International. And what that is me introducing the concept of, I think public health is at a crossroads. I think the public trust in public health, the politicization of public health is gotten to where I think it's jeopardizing the principle of medicine in public health. So I very much worry that governmental public health is able to survive and come out and actually be as academic as any other branch of medicine. That one of my plans for the future is I have created, and I actually did this many, many years ago, good 10, 15 years ago, a consulting company called Public Health Solutions International, that if I am seeing that the governmental public health is not able to weather COVID and monkeypox and still maintain credibility, then maybe it's time to privatize public health and actually get forward and get more aggressive and more cutting edge. So here I am just dropping that for the first time for you all here. I've been speaking at this conference for, 10 years plus. This is the first time I'm talking about that. So again, no relevant disclosure. We're going to talk about Mycobacterium. all Mycobacterium are really unique. They have this wall that is just unusual. It's made up of lipids, so it's a lipid wall. And so this is many of the reasons that they evade the immune system. They're hard to treat, they're hard to kill. It's a very difficult and unique bacterial cell wall. Most of us have heard the word acid fast, and this is what it looks like. It is when you use this Kennewick stain, the bacteria, the Mycobacterium, turn red. It's also where the term red snappers come from. Red snapper is tuberculosis or Mycobacterium, and that's what it looks like. There's also agar that we have used traditionally to differentiate different Mycobacterium. This happens to be Kansassii. They look very different. These are colony growths. The technology for diagnosing Mycobacterium is so automated now that most people in labs don't have the ability to look at a plate and say, boy, that looks like Kansassii. And where do most of your specimens for Mycobacterium go to? When you send a clinical specimen, where do they go? LabCorp? I'm asking. This is a question. LabCorp. Where does LabCorp process acid-fast stains and cultures? Seattle? No, it's usually a centralized single space in the United States. So this is why it takes so long. So long gone are the days where you do an acid-fast stain, you get someone to do sputum, they run it down to the lab in Cadillac, and Mycobacterium is identified through acid-fast stain, and a sputum result comes back within 2 to 3 hours. Those days are gone. It takes you, I would imagine, at least a day to get an acid-fast stain back. So we are becoming so centralized and so automated in how we diagnose things that timeliness of getting some of these specimens or accuracy of doing these specimens is very limited. It's always interesting when I go around the globe, I'll go into a lab, say in South Africa, and this lab used to be full of microscopes and just endless microscopes. Now it's got these things that look like Keurig machines sitting on the countertop. They're rapid diagnostics for acid-fast and Mycobacterium, and it speciates, and it uses some of these new techniques like BACTEC, and they're very rapid. And so last time I was in this lab, it was a centralized lab, I was like, where are all the microscopes? And the person points out underneath the counters are all the microscopes, and they're all covered in dust, and no one uses them anymore. This is the future of diagnosing Mycobacterium. It is centralized, automated systems that take longer. Okay, here is the improved isolation media. You can see the blue bar here is the traditional egg media. Then we went to agar medium, which is the purple, and it takes anywhere, and this is days, okay, so this is how slow TB grows, 30 days. Now using these automated BACTEC system or broth methods, 10 days. So at least the diagnostics for culture is much less than 30 days, it's 10 days. Could you imagine, hey, I want to know if I have COVID. Okay, we'll let you know in 30 days. What about monkeypox? Yeah. This is at 8 weeks. This is classic Mycobacterium tuberculosis. Looks like a fried egg on agar, Lowenstein-Janssen agar. So there's lots of Mycobacterium, lots. They're in the environment, they're full, they're in your water, they're in your soil, they're in people. Here are the ones with the arrows that are the pathogenic species that we worry about. Things like Mycobacterium tuberculosis, Mycobacterium leprosy, Mycobacterium bovis. That's what we make the BCG vaccine out of, but it is also cow tuberculosis. And you can still get infected. One of the main reasons we started pasteurizing milk in this country is because many people were getting Mycobacterium bovis. So it's not uncommon, especially in eastern Washington. You'll see 85, 90-year-old gentleman who grew up on a dairy farm comes in with a big testicular abscess. They think it's cancer. They open it up. It's Mycobacterium bovis. This little kid, who's now 90 years old, has been harboring that Mycobacterium from the raw milk he drank on his farm that he grew up in Omak. That's not an uncommon story. So Mycobacterium bovis. And then with the presentation of HIV and AIDS patients with really immunocompromised conditions, we saw opportunist mycobacterium like Mycobacterium avium complex. And we'll talk a bit about MAC. What do you do when you get a culture positive for MAC? What do you do when you get a culture positive for Mycobacterium tuberculosis? So these come with different clinical syndromes. Mycobacterium TB can infect, I have seen it infect every organ system in the human body, including kidneys, uterus, testicles, brain, bones, skin, you name it. TB is, there's a good saying that as I get towards the end of my career, I really bacterium work. Thank you. Yay, good job. This is the way Mycobacterium work. You breathe in Mycobacterium, they land in your lungs, your immune system goes after them, but it gets in your bloodstream and it disseminates throughout your entire body. Mycobacterium are sepsis. They are bacteremic spread. That's why you can get Mycobacterium or TB in any bone or body part, is because it's spread primarily through the blood once it's been inhaled. So it usually presents in the lung, though. So that's why most of us, when we think of TB, we think of pulmonary TB. But it causes extrapulmonary, and especially in people, not just HIV, but anyone with an immunocompromised condition can have the weirdest presentations of tuberculosis. So here's my goal by the end of this talk is to turn you into epidemiologists, clinical epidemiologists, so that when you walk up to the room, you pick up that chart, and it says 70-year-old Hispanic male with 20-pound weight loss and a chronic cough, your epidemiologist says that's TB until proven otherwise. I know you're going to order a COVID test, and God forbid the guy has any blisters on him, you're going to order a monkeypox test, but really the epidemiology is going to point to things like tuberculosis. Mycobacterium avium intracellae can be asymptomatic. You can get colonized with Mycobacterium. So this is complicated, because what if I told you I isolated measles from you, from your nose? You've got measles. It's simple, right? And it may present differently, but now I'm telling you I'm going to isolate Mycobacterium from you, but it doesn't mean you have disease. It just means you're colonized with it. Dang, we still struggle with positive strep results. Everyone who has a positive strep, I guarantee you tell them they have strep throat. It's probably not true. Probably a third of those folks are just carrying strep and are colonized with it. But it's easier to think with a lab test than think with your clinician brain, which is your epidemiologist brain, okay? So we'll talk a bit what it means when you isolate Mycobacterium avium intracellae. It could be just colonization. It can cause pulmonary disease, so very much like TB. The way we usually find Mycobacterium avium intracellularly, or MAC, is because you're thinking the person has TB, and then the culture comes back 30 days later with MAC. And then you have to sort this out, and how do I treat it, and what do I do? And we'll talk through this. Unfortunately, very much like Mycobacterium tuberculosis, once you breathe it in your lung, it goes into your bloodstream. and you can get disseminated disease. Okay. Leprosy, very straightforward. Have any of you ever seen a patient with leprosy? Yeah. It's a very fascinating disease. It tends to be gone. If you've ever go to Hawaii, I'd really encourage you to go to the leper colony. There are still people with leprosy living there to this date, and it's a really interesting understanding of how this mycobacterium has worked through the years. And then other pulmonary diseases due to other mycobacteria such as Kansasii, Marinum, ulcerans, fortuitum. We'll talk a bit about these. Granuloma. We hear this all the time. By the way, if you're a radiologist and you're in this room and you read me an x-ray and says granuloma seen on chest x-ray, I'm going to ask you, what microscope did you look through? Because you cannot diagnose a granuloma on an x-ray. So don't say that, okay? What a granuloma is your immune system. It's a whole mix of multinucleated giant cells and T cells, all surrounding Mycobacterium with an epithelioid cell also doing this. And it creates a little encapsulated area which doesn't kill Mycobacterium. It just surrounds them. So we're going to talk a bit about when you are exposed to TB and you become infected, why doesn't that turn into disease? And the granuloma is probably one of the best answers, is because it evades your immune system but doesn't give you disease. It also isn't infectious, which is helpful, but that's a granuloma. So let's talk about these non-tuberculous mycobacterium, or NTM. And I'm sorry, we use these acronyms all the time. So NTM. They're slow growing. The most common one is MAC, Mycobacterium avium complex. Kansasii and Xenopi are two of the other most common ones. Then there are rapid growing ones. So this is how we differentiate. When I am thinking someone has NTM and I get a culture and they tell me, wow, this is a rapid growing, I already know what it is. It's probably abscessus, which is the most common. Or it could be fortuitum. I already know, and everyone's like, oh my gosh, how did you know? And it's like, it's just basic understanding of Mycobacterium. Rapid growers and slow growers. TB is a slow grower, by the way. So if someone tells me they can speciate that organism in 2 weeks, it ain't TB. Okay, so while the prevalence of TB has decreased in the United States, and we'll talk about that in a little bit, NTM has gotten worse and higher than TB prevalence. Why do you think that is, by the way? Any thoughts to that? Why is NTM more common now than ever before? Yep, we do really good at finding TB, and guess what? Our population, hate to tell you this, you probably know this already, coming from a pediatrician, our population is older, and they tend to be immunocompromised in some condition whatsoever, like I'm not talking about HIV, although we do have HIV. It's immunocompromising conditions of the lung, so it could be steroid use, it could be other things. We just tend to have, and do any of you work in the prison system? You know, the population in prisons now is older and sicker than it has ever been before, okay? This is why we see more NTM than ever before. The most common species are MAC, 64 to 85% of the cases. So if you only want to listen to 85% of this talk, just focus on when I say the word MAC, Mycobacterium avium. There is some geographic clustering of these depending on where you're at, such as Southeast US has Kansasii, and Kansasii is more, abscessus in the south and Kansasii in central and southern United States. We don't tend to have a lot of these here in the Northwest, but the population also tends to be much more mobile now than it ever has been in the history of the United States. Lots of movement around the US. So what are the risk factors for non-tuberculous Mycobacterium? Underlying lung disease, straight and simple. COPD, bronchiectasis, cystic fibrosis, prior lung transplant. These are the folks that get NTM. That immunodeficiency or immunosuppression is associated with defects in interferon gamma. And steroid use is at an all-time high for us right now. Other really common findings in the demographics of NTM are female sex, advanced age, thin, low weight, scoliosis, pectus defects, so chest defects, and mitral valve prolapse. These are the folks that are at highest risk for NTM, and not unexpected. Okay, so the ATS, American Thoracic Society, and the Infectious Disease Society of America created this diagnostic criteria for NTM. We don't have to belabor this. This is really for your reference. This really sets the criteria for bugs that can colonize you that don't necessarily mean you have disease, okay? So you have to have both of these things. You have to have pulmonary symptoms, such as a nodule or a cavity on chest x-ray or CT that shows multifocal bronchiectasis with small nodules, and you gotta exclude other diagnoses that can do the same thing, okay? But you have to have this positive culture result on at least 2 separate sputum samples or from a bronchial wash. Okay, so you have to have the presence of the bug, presence of disease not explained by other things, and that really is what is going to set your diagnosis. I know it gets really confusing. You can't just make a diagnosis based on what grows on a culture. It's not that simple. So here's the workup. You have an elderly woman who is on chronic steroids, who has a chronic cough. You worry she has tuberculosis, but she has no epidemiology for tuberculosis, which I'll tell you, very frank, is foreign-born folks are the majority of TB cases in Washington State right now, okay? But say she's not foreign-born, she hasn't been homeless, she hasn't been in jail, but she looks like she has TB, you are gonna think non-tuberculous Mycobacterium. Chest x-ray is adequate. Okay, you can do a CT if you want to, but chest x-ray is adequate, plus sputum results. Specimens, fine if they're induced, fine if they're just created. You don't have to do a bronch, and if you get those results, that's your workup. Now you can do a bronchial lavage. A lot of times these folks have pulmonologists involved, so I think a pulmonologist is the best person to call whether a lavage is safe and is going to have return. So work with their pulmonologist if they have one. And you obviously have to exclude TB. You're getting the specimens. It's easy to do. By the way, here's an insight to TB. The best place in the country that I have experienced doing this now for 20 plus years is the State Public Health Lab in Shoreline. It's free. They see all the TB in the state, and they do it very quickly. It can be done within a day. So you'll get your results faster than you'll get them from LabCorp. So talk to your health department to send your specimens for TB to the State Public Health Lab. It's free. All right. Unlike most other bacteria, it's really confusing what drug susceptibility means. Few non-tuberculous Mycobacterium, for example, Kansasii, have any clinical response correlation with the susceptibility tests. So if you're thinking like a urinary tract infection, I'm going to find out what organism it is, I'm going to find out what bug it's sensitive to, and then I'm going to put it on that antibiotic. It doesn't work that way. Really is a prescribed course, and it's usually macrolides, and we'll talk about that here in a sec. But culture results, really not that helpful. So here it is. My approach based on this ATS and IDSA guideline recommended therapy daily or 3 times a week, azithro, rifampin, and ethambutol. IV amikacin if they've got cavitary disease, and this is the front line for treating non-tuberculous Mycobacterium. This is not the prescription for someone who has a culture positive for an NTM. They must have clinical disease before you subject them to pretty heavy-duty antibiotics. So Kansasii, a little different. We don't see it too much, maybe a couple cases a year. The main treatment for these is rifampin, ethambutol, and isoniazid. 12 months of negative sputum cultures, though. That's really hard to do. How good are you guys at taking meds? Lots of studies on this, by the way. Who do you think's better at taking meds, men or women? Women? No, equally terrible at taking meds. And I'm going to disavow you of this belief. You think you have this magical belief as a clinician of knowing who's going to take their meds. You don't. Clinician correlates with who they think are going to take their meds, and those who actually do is terrible. It's better to flip a coin. So who's better, adults or kids, though? Right, they're equally awful. So, and I was branded with this principle, and I'll just share it with you. When I was an ID attending many years ago with a full head of hair, I enrolled in a new study about this medicine that grew hair or prevented hair loss. And my friend was a dermatologist, and she said, hey, why don't you join this study? You've got male pattern baldness. And I was like, no, I don't. And so I went into this study, and they shaved off a thing about this big on the back of my head. And I was like, dang, that's pretty obvious. And then they put a tattoo in the middle of it, so that when they came and put the camera on it every month, they could measure hair density. All right, now I'm pretty dang motivated to take this medication because I got a bald spot here now, and I got a tattoo on it, right? I got kicked off the study because I didn't lie. I actually couldn't take a pill every day. I tried. I really tried. But I came back with my pill bottle. I didn't dump them out before I came back to the study, and they said, look, 3 months in, you're not a good patient. You don't take your meds, and we're going to have to discharge you from the study. So after this lecture, you can come up and look at my tattoo because it's more. So, but I kid about that, but what it tells me is I'm an educated person. I'm a motivated person to take this medication, and I couldn't do it. So I know what you're all thinking. Thank goodness he's not in charge of birth control in his family. Actually, I was. But the point is, it taught me a good lesson that even I think I know who's going to take their meds. You don't know who's going to take your meds. And taking your meds for 12 months is really hard to do, okay? So how do we ensure patients take their meds for 12 months? Yeah, directly observe therapy, give them incentives, give it to them, have them present to the pharmacy. It's going to be pretty hard to convince someone with a chronic cough that you got to take this med every day for 12 months. And I'm going to do these sputums. Some people do. This is why the treatment is so poor for non-tuberculous mycobacterium. You guys in dealing with incarcerated person, it's a little bit easier. I got to give it to you because you have them available, and they tend to be very polite, and they take their meds for the most part, better than the general population. But just understand, treating Mycobacterium is a really hard thing to do for 12 months. Okay, abscessus, a little bit different. The effective treatment options are pretty limited. Macrolides alone, not appropriate. They have a lot of macrolide resistance. Combination therapy with amikacin and cefoxitin or imipenem might result in clinical improvement, but no antimicrobial regimen has result in long-term negative conversion of sputum samples. Antimicrobial therapy plus surgical resection may provide the best chance for cure for people who can tolerate it. And this is for abscessus. Very nasty Mycobacterium. Defining resolution or cure of NTM should take into account the number of negative cultures you have, duration of antimicrobial therapy, and the improvement of symptoms. I think improvement of symptoms is probably one of your best measures. Weight gain, in my experience, has been one of the best clinical diagnostics of someone's getting better, whether it's TB or it's atypicals. TB is called consumption, traditionally, because it consumed you and you became very thin. When a TB patient starts gaining weight, you know they're being treated, okay? That's a pearl to pass on. Okay, some of the adverse events with these drugs, such as macrolides, ethambutol, these are all pretty common things. I have seen all of these. And I worried about this. We were treating TB patients, and some of the private practice docs wanted to take over the therapy for a TB patient, an older person who went blind. And when I went back and looked at their dosing of ethambutol, because they're not used to dosing ethambutol, was 4 times the recommended level, and they made this person blind. Now, usually ethambutol eye toxicity resolves after you get off the meds, but this gentleman never saw again due to his side effect of ethambutol. So none of these are to be taken lightly. You guys use macrolides all the time. You probably use rifampin or rifamycins fairly regular, but aminoglycosides, we don't use that often. So just be careful. Probably get someone to guide you through these. Defining when someone is actually failing is lack of clinical response after 6 months of appropriate therapy, time to get an ID doc involved or a pulmonologist involved, or reemergence of multiple positive cultures beyond that treatment of 12 months. And then again, recurrence is relapse, which is reemergence of positive cultures after you've stopped therapy. This stuff is really hard to treat. So when you have macrolide-resistant lung disease, I take it with a grain of salt, but treatment success has been reported with parenteral, so IV, streptomycin or amikacin, along with surgical resection. It's also, amikacin is available in liposomal suspension for inhalation. And these are some of you're out on a limb here. Don't be doing this as a primary care doc without some guidance from pulmonary or an ID doc. Very sticky. Same way, and don't do your own surgical interventions either. Okay, let's talk about TB. So you're exposed to someone with tuberculosis, greater than 8 hours, breathing in that bug, lands in your lung, you're infected. I do a interferon gamma release assay, and it's positive. You are infected with TB. That is what we call latent TB. It means you've got the bug in you, you've got it contained by your immune system, you're not infectious, your test is positive, don't freak out, okay? This is what usually happens. I get a call every Friday evening for someone who's got a positive skin test and they need to report TB. And I have to walk them through what I'm telling you right now. That isn't TB, that's latent tuberculosis infection. They're not infectious, and I know this because you did a chest x-ray, right? Yeah. Was the chest x-ray normal? Yes. Do they have any lymph nodes? No. Are they really losing weight? No, they don't have any symptoms whatsoever. That, by definition, is latent TB infection. About 10% of the people with a latent TB infection will go on to develop disease, which is the next phase, which is called tuberculosis disease, which is usually a cavity in your lung or wherever it landed when you were bloodborne with the initial infection. 10% of people that are infected, positive skin test or positive IGRA, will go on to develop disease. It depends, your entire lifetime. Depends on your immune system. If you are full-blown AIDS, it's 10% per year. You live 10 years, you're gonna have TB, okay? These are gross oversimplifications, but the point is, you guys have to do something that we are really bad about in medicine, and that is discuss risk with patients and translate risk. What does a 10% chance of developing disease over your entire lifetime mean? The most dangerous thing your patients do is get in their car to come to your clinic, right? But they'll focus on, oh my gosh, I don't want the COVID vaccine, it's too dangerous. What? The risk of vaccination isn't even on the same level of the car you just got in to get to this clinic. But fortunately, 10% risk of developing a deadly disease over your entire lifetime is easy to translate to a patient. That's the numbers you use. 10% chance of developing bad TB, lung disease, over your lifetime because you are infected with TB. Now that's hoping that it's drug-susceptible TB, and it isn't a multi-drug resistant strain you got from wherever you're from. But that's the difference between latent and TB disease. So let's talk a bit. It's spread person to person through the air. Very, very few things are spread through the air. I know we like to kind of fantasize science fiction about infectious diseases, but very few things. Name the things that can be transmitted through the air. If you can get to 6, I'll buy you guys a cup of coffee. What's 1? Measles. It's classic. The most infectious agent. And now I can use this term that I've never been able to use before, which is R-naught, because now we use it with COVID all the time. The R-naughtiest of all organisms is measles. Very infectious. Okay? There's one, spread through the air, measles. What's another? What? COVID. Yeah, a lot of debate in the beginning. Was it airborne? Was it droplet? But I think most of us agree it's airborne. The R-naught of COVID is pretty low, though. It's not near what measles is. There's another big player in here, chickenpox. Okay, so aside from TB, measles, chickenpox, and maybe COVID, there aren't a lot of things spread through the air, but TB is one of these things that spreads person to person through the air. Usually attacks the lungs. These are all the things we talked about when I was giving you these terms, so we're all on the same page. Not everyone who gets infected with TB becomes sick. 90% of the people who get it infected never develop anything. How can you prevent it from going on? Well, we'll talk about that. You can treat the few bugs you have in your chest from infection, but TB is not a disease of the past. It is the world's top cause of death due to infectious disease. World, not US, world. TB is not a disease of the past. A lot of people in the United States still have TB infection and TB disease. But in 2019, there were only 9,000 cases of TB in the United States, which is the lowest number we've had on record ever, and that's pretty good. But it can still cause people to become very sick if they're not treated, and treatment is here to prevent. I do not like this word, prevent. You are actually, when you're infected, maybe you only have 100 organisms in your chest, you're treating those 100 organisms with INH or rifampin so that you don't develop disease. You aren't preventing anything, you're treating, but we use this term all the time, prevent disease. You're treating the infection. And then treating disease is much more complicated, and we'll talk a bit about that. So here's the epicurve of where are the cases over time, and you can see it's gone down. What do you think that bump in 92 was from? You younger clinicians need to understand this history. It was AIDS. This is what happens when AIDS and TB are mixed. You get a resurgence of TB in the United States. So that was our AIDS epidemic. Spreads through the air. Latent TB versus TB disease. I really walked you through all this. This is really just for your reference. This is the presence of the organisms without signs or symptoms or X-ray findings or sputum sample of disease. Now, if someone has a positive skin test or a positive quantiferon and their chest X-ray is normal and they have no symptoms and they don't have any lymph nodes or a big bulge on their back, which is an abscess, then you don't have to do sputum samples. You can just treat the few organisms that are in them so that 10% doesn't go on to develop disease. The cure rate, although we cannot do these studies anymore, the cure rate is well over 90% if you treat with appropriate antibiotics to prevent that person from being that 10% that develops disease. All these studies, unfortunately, were done in Alaska Natives back in the 40s and 50s, where they randomized people to receive or not receive. That is not ethically okay, so we don't do studies like that anymore. But we know the efficaciousness from those studies was well over 90%. Not everyone who's infected will become sick. Here we are. Untreated latent TB can lead to TB disease. If your immune system is not normal, your chances of developing disease are higher. It's estimated that about 13 million people in the US have latent TB infection, and that the treatment is 90% effective, like I just said. What we see with TB cases or TB disease is just the tip of the iceberg here in the United States. Most of the burden of TB is in latent TB infection or people that aren't recognized. COVID has not done us any favors. Everyone that comes in with a chronic cough is thought to be COVID. They do a COVID test, it's negative, you get sent on your way, or you get put on Cipro for your bronchitis. And they come back with TB. Or our death rate due to TB in this state has gone way up as we're missing diagnosis. We, all of us in this room, myself included, are missing the epidemiology that just hits us right in the face. Foreign-born, homeless, immunocompromised, you got TB. No one ever did a skin test, and on autopsy, people are seeing huge granulomas in the chest, and they were infectious, and then they have an abscess on their brain from TB, and that's how they died. And the diagnosis on that death certificate is COVID. Because, my goodness, they had a positive COVID test, but we missed it. Okay, so be really open-minded about these things right now. It's not all COVID. The symptoms of TB are the classic night sweat, fever, chills, weakness. Weight loss is one of the key ones. Consumption, it's called consumption for a reason. Very interesting if you read some of the remedies in the 1700s for it, and it wasn't all women, but it was mostly 1700s women, for weight loss was to inject yourself with TB or eat worms. Seriously. Okay, that'll give you no appetite. Cough lasting longer than 3 weeks, pain in the chest. Some of this stuff is complicated and confusing, but these are the main TB symptoms. Oops, wrong direction. People that develop disease, that 10% that go on to develop a cavity, don't have 100 bugs they're spilling millions of bugs now. They are the ones that are sick and can spread the disease. Yes, when you are identified as a case of TB, the public health system goes out and tests everybody around you to make sure that you didn't become infected. And if the kids of the mom who has disease test positive, they get a chest x-ray, and we look for not just infection, but disease. 50% of all pediatric cases in the United States are found through contact investigation, not by going to your doc, okay? So it's important to identify people with disease because they are the ones that can spread TB germs. Yeah, this is just a review for you all. Who's higher risk for becoming infected? Okay, so I'm being really careful about these words right now. What puts you at better risk for getting infected, for breathing in the bug? What are those things? What do you think they are? You had to be around someone who had infectious TB. That usually means someone who's come from a country where TB disease is common. For us in the United States, and definitely in Washington State, is Mexico, the Philippines, Vietnam, India, China, Haiti, Guatemala, and this or that countries. Sometimes it's ex-Russian countries have higher rates of TB. So the majority, and I've said this already, the majority of our TB cases in Washington State are in foreign-born individuals. So you as an epidemiology clinician, if you have a foreign-born individual presenting to your office with any of those signs or symptoms that could be TB, you really got to have TB on your differential diagnosis. Fine, put COVID on there if you want to, but TB must be on that list. So that's what puts you at greater risk. The other thing is your occupation. If you're a healthcare worker or you work in high TB transmission areas such as homeless shelters, jails, and nursing homes, then you're at higher risk for getting infected. Okay, but like we said, only 10% of people that get infected go on to disease. Here you go. Non-US born, 71% of the cases in the United States. In Washington State, it's about 90%. Here are the most common countries. Kind of went over those for you. So once you're infected, who develops disease? Because healthy 20-year-old women don't tend to get TB. Who gets TB? People who have HIV infection, people that are substance abusers, anyone that's on immunosuppressant drugs. There's actually, there's TV ads now for if you're going to go on this anti-immune system drug, you got to get tested for TB because it really lowers your immune system. Organ transplants, kidney disease, head and neck cancer, diabetes. Here is the one that is just blaring in our epidemiology in Washington State now. There's so much type 2 diabetes that majority of our TB patients have diabetes. It's phenomenal. Medical treatments such as corticosteroids, those with silicosis, or those with very low body weight. Very interesting. I have found that people that develop TB tend to have this body type of very long torsos, very broad-chested, maybe pectum, and those are the most at risk of any category on this list, is your body type. It's also your genetics. All right, 2 types of tests. I've already alluded to them. There's blood testing, huge advancement in the accuracy of testing. And then there's the TB skin test that many of us are used to doing. You still got to do a physical exam, and you still got to do an x-ray to make sure someone is not just infected, that they don't have disease. TB skin test. You know, we were talking about the new monkeypox vaccine can now, instead of being injected, can be injected just like this, like a TB skin test, and we can make 5 doses out of a single dose now. It's as efficacious by doing this intradermal placement. Here's the thing about the skin test. I never trust someone's reading of a skin test. They cannot read it. Some people can, but it is not a consistent skill that people have. One, it's not a consistent skill to put it on, but it's also not a consistent thing. Most people will read the redness, but what you really have to read is the induration. And the only accurate way I've ever seen to do it, wow, that was good, is to take a pen, a pin, and you run it along the skin, don't look at it, and it'll stop. You mark where that is, come from the other side, run it, don't look at it, boom, it'll stop, mark it. That's called the pen test, and that then measure that induration. That's an accurate measure. But we struggle with quality assurance around skin testing. By the way, if you put a skin test on Thursday, you can't read it till, I'm sorry, hon, what was that? 10 minutes, okay, thank you. You put it on Thursday, you can't read it. You have to read it within 72 hours. So don't even think of saying, well, I asked the patient on Monday if it was swollen and red. Dang, you do not ask your patients to interpret their own CBCs, do you? So don't ask them to interpret a skin test, because they aren't going to measure it. They don't know how to do a pen test. The sensitivity of a skin test, given, and this is 2 years in my public health school wrapped up in like 30 seconds here. Sensitivity of a test is one thing. Prevalence of a disease that you use that test in a population predicts the positive predictive value. So with tests that sound fairly sensitive, 90%, in a population where the amount of TB is incredibly low, makes the positive predictive value of a skin test less than 45%. Flip a coin, you'll get better results. Okay? I'm not a fan of the skin test. Okay? And people still use it because, well, we've always done it. Well, okay. We always used to ride horses too. I have a car. I have a Tesla. No, I don't have a Tesla. I wish I had a So I'm not a fan. I'm a fan of the TB blood test, the IGRAS, the interferon gamma release assays. It measures interferon. It's a single test. I go to a homeless camp, I can draw blood. I don't have to come back in 72 hours. I can read their skin test. All right, we'll talk more about interferon gamma if you want to. People that get vaccinated with BCG, bovine tuberculosis, can still get TB disease, and it cross-reacts with the skin test, not with the interferon gamma release assay. So the TB test for people who've received BCG, which are usually foreign-born folks, is the interferon gamma release assay. All right. Treatment, like I said, can prevent development of disease, but it actually kills the organisms. It's short, doesn't cost too much, has very little side effects. And before you start treating someone for LTBI, you have to have done the disease, the history, the chest x-ray. And here is your regimens. You don't have to write this stuff down. You can have these slides, and it's on there. It used to be INH was 9 months, and we did it daily. I haven't used INH in years. I don't even use 6 months of INH. What I go to is 4 months of rifampin. 4 months, daily. Very little side effects, doesn't cause a lot of hepatitis. People tend to tolerate it. Rifampin, daily for 4 months. That is my go-to medication. Here is the treatment for TB disease. The point of this slide is not for you to understand everything on here. These are the approved regimens in the United States. The more organisms you have, the more drugs you have to have. So usually treatment of TB disease is 4 drugs: INH, rifampin, PZA, and ethambutol. Once you know what the susceptibility is, you can drop one of them off. And then it's usually 6 months, maybe 9 months if they're not responding well, of treatment with 2 to 3 drugs. These are the regimens that are approved. You can read those on your own. Honestly, if you're to the point of diagnosing someone, you've done a sputum sample, you've ruled out NTM, it says Mycobacterium tuberculosis on it, you are mandated to report that to the public health system, have them guide you through treatment, okay? This isn't something that is worth trying to learn on your own. There are new regimens, rifampin and moxifloxacin, 4-month regimen. It's the newest. I'm just giving you a preview of the newest, latest, and greatest. 4 months. I told you it's usually 6 to 9 months. Here we are in a new era of 4 months of adding rifapentine plus moxifloxacin, and that these are the conditions you can use that in. Again, I don't think this is good decision-making if you don't see TB a lot. Do this in consultation with the infectious disease doc. Jimmy, I hope you're on the phone, or at least watching, or the public health system. Larry Yeka here, master of TB. He's been doing it for a long time. None of this is going to be a surprise to him. Oops. Okay. When you have someone on therapy, you don't have to do baseline unless they have HIV, they have a history of liver disease, are fairly regular alcohol users, or they're pregnant or in the first 3 months after delivery. Otherwise, you don't have to monitor disease. But if they're abnormal, you better repeat them at least monthly. And if a person has elevated liver enzymes, but they don't have symptoms, you see that about 10% of the time in people with INH, it usually goes back to normal. And you can continue treating them as long as that ALT upper limit, so ALT, say your range is 20 to 40, if it's not higher than 3 times 40, 120, and they don't have symptoms, you can keep going, okay? Until it gets 5 times higher. Okay, have some time for questions? Okay, that's a lot of ground to cover, by the way. All Mycobacterium, latent TB, and TB disease. So I just rest assured you have these slides as reference. Rest assured you have the public health system, you have Jimmy and ID docs that can help you manage patients. It's getting to the differential and having index of suspicion is what I really want you all to have. Okay, any questions about all this? It's That's a lot of information. Yeah.
Thank you. I'm an otolaryngologist, and one thing you didn't mention with the non-tuberculosis mycobacterium that I used to see occasionally were they were kind of cold abscesses in children, usually 5 and under, that would show up. They were very typical in appearance, and we were always never quite sure the best way to treat those.
Yeah, that's a great question. And just to be honest, I didn't talk about a lot of things in TB here. I gave you a very quick overview. What my approach to these, and what we're talking about, is kids have lots of lymph nodes in the anterior cervical chain, and usually in the anterior cervical chain is not where Mycobacterium tuberculosis gets you. When you're a kid, it gets you in your chest, so the lymph node's in your chest. So when you see a big lymph node here, you should think staph or strep. But TB is also well known for doing this. Cervical adenitis from TB. So this is my principle, and I know people aren't this conservative. I never stick a needle in one of those until I know that they've had an interferon gamma release done. You put a hole in that, that thing will drain forever. You will never get that to heal up. If you put a skin, what I do is I put them on treatment for staph or strep, put a skin test or an interferon gamma on them, then I have them come back. If it got smaller on antibiotics, it's likely staph or strep. But if their skin test or their interferon gamma is positive, take the node out. So they go to surgery, open it, take the entire node out. That's treatment. And then you put them on treatment, INH or rifampin, and you treat them, and then it tends to heal. But sticking a needle in it, not a great idea unless you know it's not TB. So, yeah, thanks for bringing that up. Do you see much of that anymore here? No, not that common? It's usually staph or strep, but yeah, you're in another country. You ever work in another country where TB is high, you're going to see these all the time. Yeah.
All right. I think that's probably enough. We don't have any more time for more questions, but I guess if we have more questions, we can ask Dr. Lindquist.
Yeah, I'll stick around.
Okay, thank you.
Okay.
All right, thank you so much.